皆さんこんにちは、京都大学の吉原と申します。よろしくお願いいたします。で今日のゲストは、こちらのスライド、お手元の資料にもありますように、ジョン・ハラムカさんですね。ここにありますようにたくさんの仕事をされておりますけれども、ケアグループ、これはボストンを中心とした病院の、連合体みたいなものですけれども、そういうところの CIO、 それからハーバードメディカルスクールの CIO、 それからハーバードメディカルスクールの副学部長、教育技術担当ということでされております。昨年の10月にですね、私どもがボストンとそれからクリーブランドクリニックに参りまして、ボストンで彼とディスカッションをしたということが縁になって、今回こちらに来ていただくことになりました。で、直接彼の話を聞くというのはですね、少しギャップがありますので、私の方から少しEHR、PHR に関することをですね、少しお話をさせていただきたいと思います。で、PHR というのはパーソナルヘルスレコードということで、EHR よりももっと、情報の内容的に広い概念なんですけれども、こういうふうな、要するに病歴を生涯のにわたって一箇所に集めて患者さんが管理しよう、それから病歴以外に生活情報も含めて管理しようというふうな動きがですね、この10年間ぐらいだんだんと強まってきまして、それがアメリカと日本でいろんな展開のされ方をしています。で、日本の場合はですね、いろんなモデルがあるんですけれども、大体こういうふうなモデルでデータセンターがあって、そこに患者さんのアカウントを作って、そして例えば病院とかクリニックとかいろんなところに患者さんがかかりますよね。でその時のデータを患者さんのアカウントに集める。でそれを、例えば病院間でシェアしたり、患者さんが自分の医療記録を見るというふうなことをやると、これがEHR という考え方です。で、私どもがやっているそのドルフィンプロジェクトというのがありますけれども、現状はこうなっております。で4つ、今動いてますのが熊本、京都、宮崎、東京で動いておりまして、この4つの地域でそれぞれ、いくつかの病院が接続されたりしているわけですけれども、それがさらにお互いにですね、このスーパードルフィンというディレクトリーサービスを経由してつながっているという状態です。でこれはアメリカでもまだある意味実現されていないレベルだとは思います。ただ規模的にはですね、アメリカの方がたくさん、こういうこと、特にこの地域のことに関してはやっているということです。で、ドルフィンのサービスですけれども、患者さんに対してクリニカルレコードを見せる、いわゆる B2C ですね、ビジネスからクライアントに対してデータをサービスを提供するということです。それからクリニカルレコードを、病院間でシェアするということですね。でこれはB2B のサービスになります。で、現在先ほどの全体のモデルスキームに沿った形でこういうものが動いていて、それで今、例えばですね、病院とかクリニックなどではいろんな電子カルテが動いてますので、それを、ある程度の標準化をしてデータをやり取りする必要があります。でそのために今 MML のバージョン 2.3 とそれから 3.0、 これは CDA という HL7 の、フレームワークを使ったものなんですけれども、その2種類が使われております。でその他にも HL7 そのものが一部使われたりもしております。で、日米のですね、いわゆるその地域のネットワーク、それからナショナルネットワーク比較をしますと、まず地域に関して言いますと、アメリカではリオ、このリジオナルフェイスインフォメーションオーガナイゼーションと呼ばれる提唱されているものがあります。でこれに相当するものが先ほど説明しましたような宮崎、熊本、京都などで動いている地域のデータセンターです。で、京都の場合マイコネットというものが動いています。 それから国レベルでは、NHIN、ナショナルヘルスインフォメーションネットワークというものがありますが、これはまだ、実際に動いていないのではないかと思います。でそれが、我々の方ではスーパードルフィンということで、一部動いているという状況です。で私たちの全体の計画としてはこういうふうな感じになっていまして、これが地域で、これが国レベル、そして国際レベルなんですけれども、今現在動いているものがこれです。それから中国でここまで動いています。でいわゆるその地域のセンターが中国も一つ稼働しております。でこれを、こちらまで持ち上げて、最終的にはグローバルドルフィンというもので、ディレクトリサービスをやったり、翻訳サービスをやったりということをですね、計画しております。でこの辺りがまだ今開発中という状態です。で、最近のトピックとしてはこの U ドルフィンというのが加わりまして、これはモバイルフォン、携帯電話に対するサービスの窓口になっているんですけれども、こちらの方に携帯電話で電話をしますと、地域のデータセンターにつながって携帯で見えるというふうなことができるようになっています。で、マイコネットのトップページがこんな感じでありまして、こちらの方からログインして自分のデータを見ることができるようになっています。で現在、マイコネットはここにありますように、ユーザーが今約600名患者さんですね、まず少ない状態なんですけれども、これが京都府立医科大学が、多分7月ぐらいにはつながってくると思うんですけれども、そうなりますと相当待っているで盛んに使われております。で、実際のマイコネットのユーザーの、増加の状況なんですけれども、こんな感じでリニアに増えてきている。それから、現在のマイコネットのユーザーの年齢分布を見ますとですね、この赤いのがマイコネットユーザーで、こちらの青い棒グラフが京大病院の患者さんの年齢分布です。分かりますように40代から60代にかけてですね、ネット利用者が優に高いということが分かります。一番その健康に関心が深いという層だと思われます。それからアクセス記録を見ますとですね、サービスを開始したのが2007年の7月なんですけれども、ずっとアクセスが増えてきておりまして、曜日別に見ますと、やはりウィークデーのアクセスが倍以上多いということが分かります。土日は意外と見られておりませんで、多分これは病院にかかってその夜か次の日あたりに自分のカルテを見るということをされているんだろうと思われます。で海外の動向として、今日原向さんの方から紹介があると思いますけれども、いわゆるそのプライベートカンパニーですね、 Google ヘルスとか、それからマイクロソフトヘルスボードなどのサービスがもうすでに始まっておりまして、これは機能的には、いわゆるマイコネットのセンターみたいなものです。で、まとめますと、日本における EHR というのはですね、やはりセンターがあって、そこのアカウントを使って例えば患者さんが見るとか、それから病院同士がそれを共有するというふうな仕組みを実現しようとしています。で、これが一番多いかなと思われます。ところがアメリカの方を見ますとですね、このようにですね、病院のサービス、病院そのものがですね、患者さんに対する直接のサービスをしたり、これは紹介があると思いますけれども、それからクリニックに対するサービス、これはもうアプリケーションを使って直接ウェブアプリケーションを使って患者さんにサービスをする、クリニックにサービスをする、それからあと病院にサービスをするということをやっている。でそれに加えてですね、患者さんが例えば Google とか MSHV にアカウントを持って、そして日本と違うのはですね、患者さんがこのサービスを使いつつこちら側からログインしてデータをインポートする、これは全て患者がやるんですけれども、そういう違いがあります。ですからこのいわゆる何て言いますか、非常にリッチなサービスを病院自体がどんどんやって、ある意味その囲い込みのような戦略をやりつつ、しかもこういうですね、商業サービスをうまく使ったデータのサービスも併用してやっているというふうな状況が見て取れます。 と、政府系の方へのデータの、病院からの提供というものについてはまた説明があるかもしれませんけれども、ディスカッションの時間を取っておりますので、ぜひそこでご質問いただければと思います。
Well, thank you very much, and I'm very happy to be here. Kyoto is my favorite city in the world, so there is no place I would rather be. I had a very relaxing morning, touring many temples, so I have a lot of energy to give this lecture tonight. So, you described the electronic health record in the United States very well. The only problem is between 2 and 20% of doctors in the United States use electronic health records. Electronic health records cost $40,000 to $60,000 per doctor to implement in the United States. So we don't yet have the adoption to realize the benefits of an electronic health record. So before I start with my slides, I want to give you an update on the Obama administration's plan to spend 2 trillion yen on electronic health records in the United States. The economy in the United States is having a very significant recession. Mr. Obama has said 3 goals for the United States: more roads and bridges, schools and internet connections, and more electronic health records for all doctors. This week, the Senate and the House have just finished a stimulus package for the United States that includes 2 trillion yen for electronic health records, training, education, technology, and incentives for doctors to use electronic health records. This starts maybe as early as next week. So as soon as I get back to Boston, I will be working very hard on this. The first 2 years, 2009 and 2010, we'll have about 3 billion. So that would be 300 billion yen to start, plan, and begin training for the project. So tonight, I'd like to tell you about where the United States is going with electronic health records, with data exchange like Dolphin, and with personal health records. We'll actually look at Google Health with My Lifetime Medical Record. So the United States had to establish a plan to roll out these new electronic systems. We needed a board of directors, leaders, to decide on our priorities. The United States established under President Bush something called AHIC, American Health Information Community. And now under President Obama, it has been changed to the National eHealth Collaborative. So these organizations set our priorities. There are so many things one could do. Where do you start? And in a moment, I'll show you their plan, their strategy for how we will make interoperable, secure, electronic health records available to every doctor in the United States. First problem we had, like with Dolphin, how do you exchange data from doctor to doctor, doctor to patient, doctor to hospital? You have chosen MML. In the United States, our problem is we have too many data standards. We had to decide as a country, HL7, 2.3, 2.5, 3.0, SNOMED, ICD, LOINC, too many standards. So the Health Information Technology Standards Panel was established to bring vendors, doctors, payers, and government together to decide on what standards we would use. In a moment, I'll show you their work. Another problem we had, vendors don't use standard data exchanges. So when I was recently in Tokyo, I asked at JFCR, you're running a Fujitsu system. Can the Fujitsu system talk to the IBM system? And they said, no. So how in the United States can we make sure vendors create software that can send data from hospital to hospital? We established something called the Certification Commission on Health Information Technology, which tests software to make sure it's good enough for doctors to use and is interoperable, can send data, can be used for electronic prescribing, can be used for electronic lab transfer. Now that $20 billion I mentioned, 2 trillion yen, will only pay for software that has been certified. So here, doctors and hospitals will buy certified software because it's the only way they can get government funding. Just as you described Super Dolphin, we have, over the last 3 years, piloted in 9 cities the idea of a nationwide health information network. Now, I know this may not be true in Japan, but in the United States, no one trusts the government. So, no one wants to build a big database in the White House run by the government to collect healthcare data. So really what this is, it's like Super Dolphin. It's creating a way for hospitals to send data to other hospitals, hospitals to send data to patients. We really don't involve the government. Now sometimes there will be quality measures or public health measures like infection epidemics that we might report data on how many patients came to an emergency room. But we wouldn't send the patient's name. We wouldn't send specific private records to the government. So really, this is the standards, the products, and the way, the transport way to get data exchanged from hospital to hospital, doctor to doctor, and to patients. I realize this slide looks very complicated. Don't worry. This is the work that we have done over the last 3 years to build Dolphin and Super Dolphin type architecture. We decided, like you did, that involving the patient is very important. In 2006 and 2007, we as a country decided on the data standards for patients to get access to problem lists, medications, allergies, laboratory, radiology studies. We haven't yet done discharge summaries or notes. Those are a little bit controversial, that the patient may see something the doctor wrote that the patient may get upset by. But we'll be working on that. Laboratory. In the United States, we have 5,000 hospitals and 2,000 laboratories. Those laboratories all use different data standards. HL7, 2.3, 2.4, 2.5. We want every laboratory to use the same data standard. So as a country, we decided HL7 2.5 is the one way we will send laboratory data in the country. In the United States, you may have read about a recent outbreak of salmonella in peanut butter. We have had problems with infections, poisonings in food. We've had epidemics, if we could send data to the Centers for Disease Control or public health agencies about patients who come to emergency departments, and again, we don't need to send their name. We can send information about their diagnosis, where they live, and where they work. The government can easily detect changes, problems with infections or poisonings, and ensure that appropriate action is taken. Now, in 2007, we were asked by our Secretary of Health to work on the standards for disasters. We had Katrina, which caused flooding in New Orleans. All the medical records in New Orleans were on paper and were underwater. Every medical record in the city was lost, except for the veterans, because the Veterans Administration in the United States has an electronic record. So what we did is we figured out how to create, not only on the internet, but CDs and USB drives, storage of a lifetime medical record that a patient could carry with them in the case of a disaster. The United States has spent quite a lot of time on medication safety and figuring out how medications can electronically be sent from a doctor to a pharmacy and be safe. Now let me take a moment to just show you what that looks like. All of the electronic systems at Harvard, where I work, are web-based. Make sure my browser is working here. So I realize these screens won't translate exactly, but you'll get the idea. We have 3 million patients and over 1,000 trillion bytes of medical data connected to the internet. Now, in my trips in Japan, I understand there are many security and privacy concerns, and there has been some reluctance to use the internet for electronic records. We have found over the last 10 years that with a lot of hard work, we can make the internet safe enough. So I'm going to go into our electronic health record at Harvard and show you how a prescription might be written electronically. So I'm going to pick a patient who is a sample patient, Kermit Frog. Kermit Frog is a very sick frog on many medications with many doctors and many allergies. You can see allergic to everything. So I will go simply select the medication tab. Now Kermit is taking about 100 medications, many medications. Now this screen is interesting. There is a social networking site in Japan called Mixi. This is like Mixi for medications. Any doctor or any nurse can go into the medication list, see the patient's medications, and change them, update them, or inactivate them. And this is very important because we want a universal, accurate medication list. Now, if I want to write for a new medication, I can pick any medication, or if I have medications I write for frequently, I can just click. So, I want to write for lisinopril, a high blood pressure medication. It automatically defaults the dose, and it warns me there are many problems with this medicine because of drug-drug interactions or patients' other conditions. I'm going to decide to continue. Now, it's defaulting to 1 per day, and it's 30 days with 2 refills. I'm going to continue that. Now, because there are so many errors, so many problems with this medicine, the computer is asking me, as a doctor, to override all the decision support and saying, I understand that the patient might be harmed because of drug-drug interactions, but there is a benefit to this medication. I want to give it anyway. I now say I am done, and this medication can be sent electronically to a pharmacy. And so this patient, I could say, route this medication electronically. Now, in the United States, about 95% of our pharmacies are connected to the internet. And so this patient goes to 2 pharmacies in Massachusetts. I can say, okay, I'm not going to do it because it really will work. And in 1 second, this prescription goes electronically to the pharmacy, is filled by the pharmacist. When the patient picks it up, the doctor is notified electronically. And if the patient ever wants to refill the medication, the doctor and the pharmacy can work electronically to do that. So this system required a lot of standards. And so in 2007, we built all of the data standards to support everything you saw. How do we ensure the patient has the right drug, the right dose, safely prescribed, and sent electronically to the pharmacy? This year, the government pays doctors 2% more to use electronic prescribing. Next year, 1% more. The year thereafter, charges doctors 2% if they don't use electronic prescribing. So in the United States, we call this carrot and stick. In Japan, I think it's candy and whip. Now, in the United States, we have a big problem. 16% of our gross domestic product is spent on healthcare. We have more healthcare than any other country in the world, but we don't have good healthcare. In Japan, patients live longer. In Japan, the mortality rate is lower, but you spend half as much as we do. So President Obama wishes to reform healthcare and to begin paying for quality rather than quantity. So in 2007, we built the electronic standards to measure diabetes care, asthma care, congestive heart failure care, stroke care, so that we can see if doctors are delivering the right treatments, pay doctors for doing a good job, and stop paying for errors. Sometimes hospitals cause harm. Hospitals cause infections. The government will no longer pay a hospital for mistakes that hospitals make. This, 2008, we worked on very important home care standards. Now, we believed that as patients age, more care will be delivered in the home. Blood pressure measurement, glucose measurement, a scale. Now, with a scale, you can measure body weight, and that could be important for, say, metabolic syndrome. But also important if a patient has congestive heart failure and gains weight, that may indicate the patient is retaining too much water and is going to have a hospitalization because of congestive heart failure. So these standards allow us to monitor the patient in their home, either sending that data to the personal health record or to the doctor's electronic health record. We thought it very important that patients and doctors interact electronically. Patients can send doctors questions. Doctors can do remote visits electronically. So we developed all those standards. Now, Kyoto is a very enlightened city. When I visited Tokyo and I asked, do hospitals compete? And they said, of course, hospitals may not want to share data because then they may lose patients to other hospitals. But Dr. Yoshihara has told me that in Kyoto, there is sharing and not competition. That's good. We developed the standards so that hospitals could send a lifetime medical record from one hospital to another, including DICOM images. Personalized healthcare is about the genome and genomics. Now, as we were walking here, I noticed at Kyoto University you have an institute for genomic medicine. We wanted to develop the standards to record the genome and enable doctors to use the genome to help patients make decisions, to understand what diseases they may develop. So I feel very passionate about helping the United States with these standards. So I contributed my genome to this project. So I am the fourth human to have my genome entirely sequenced. So I know, because we used my genome in this standard, I am twice as likely as an average man to develop prostate cancer. I am susceptible to tuberculosis, and I carry a neurological disease called Charcot-Marie Tooth disease. Now, what's really interesting, my genome is available on the web to any researcher in the world. Now, we won't do this for anybody else. This is just because this was the first. A researcher in Germany looked at my genome and found that I carry 6 genes for glaucoma. Now, in Japanese, what is the translation of glaucoma? Can you, So, I had not had the pressure in my eyes checked in 5 years. So, last year, I went to the eye doctor. I have glaucoma. And so my genome told me to get my eyes checked, and now I take medication for my eye pressure. So I think this will be very important in the future as all of us have our genomes sequenced. The cost of doing a sequence was quite expensive. My genome sequence cost about $10,000, and by the end of 2009, $1,000. So in yen, 100,000 yen. So, not expensive. We also have worked on the standards so that public health departments can get infectious disease information, and immunization records for children and adults can be kept for a lifetime electronically. In 2009, we'll be working on many standards, but an important one that I did not show here is clinical research. We recognize that data for care is important, data for public health is important, but also data for research. What if a clinical researcher wants to look at, does Vioxx cause heart attacks? giving researchers access to anonymized, de-identified data to do data analysis and mining is important. And we'll develop those standards this year. So this is the current use of EHR in the United States. There are many states where only 2% of the doctors use EHR. Depending on how you define an EHR. Now, I'll show you our EHR again in a moment. In Massachusetts, we are actually up to almost 50%. So we're doing okay. But as a country, I mentioned, there are now going to be incentives from the government to use EHR and e-prescribing. And many of our insurance companies are now requiring doctors to use electronic systems. They have told doctors, we will not pay you unless you use electronic systems. Now in the United States, many hospitals are helping doctors buy an electronic health record. So as I mentioned at the beginning, well, doctors don't have a lot of money, and electronic health records are expensive. So a combination of the government and hospitals will help them get electronic health records in their office. So last year what I did, I built a $10 million data center, which, so 10 million, I guess that's, let's see, 100 million, so 1 billion yen, to host electronic health records for hundreds of doctors using an ASP model. Doctors use a web browser and use nothing more than the internet, a laptop, and the browser. They do not require software or hardware in their office. And this has helped us accelerate electronic health records in the Boston area. Now, what do I mean by an electronic health record? So let me show you, again, our electronic health record. Okay. So I'm going to go and pick this patient again. An electronic health record to us means an active problem list. And in this case, again, it's like MIXI. Every doctor, every nurse can come in from every department. You can see we have cardiac surgery, endocrinology, general medicine, and maintain the problem lists for the patient. We electronically record every lab test, urinalysis, pathology, cytology, microbiology. All tests are reported electronically. Every report that has ever been written about a patient from every department is electronic. You can see all the department names here. Every note, discharge summary, progress note, operative note. The way we get these notes into the electronic health record, doctors type, and we have templates to do that. But they also dictate. Our voice recognition system enables them to pick up a cell phone, dial a server, dictate, and then their voice-recognized note is put in the electronic health record. I showed you medications. All of our ordering of laboratory, radiology, other diagnostic studies are all done via the web. And importantly, we have created a view that puts a lot of data together. So for example, suppose Kermit is a diabetic. Now for diabetes, I'm concerned about eye exams, foot exams, tobacco use. I may be concerned about labs like hemoglobin A1C, cholesterol, triglycerides. So we take all of the data that is important for diabetes treatment and place it on one screen to make it very easy to access. And we do this for other diseases, such as patients who are on Coumadin, and you want to track their anticoagulation parameters and platelets. Now also, what we've done that's important, chemotherapy is all electronic. So if a patient has cancer, the doctor specifies their disease and a cancer treatment protocol, and then the computer does all of the dosing of their chemotherapy and other medications automatically. Now, you may worry the computer is doing too much, and the doctors might be worried that they have lost the art of medicine. Well, this system was built by our doctors. The doctors tell me it's their system. They wrote the rules. They wrote the decision support. So they feel the system is helping them, not competing with them. So this kind of web-based electronic health record has been very successful for us. Here I am in Kyoto, where, let's see, it's 3:47 a.m. in the morning for me, and I can access 3 million patients securely. Now, just so you're not worried, I spend over $1 million, so again, 100 million yen every year on security. I have teams of people protecting the electronic health record from viruses and hackers on the internet. And so we work very hard to make this work. But I hope that the Japanese government sees that it is possible to use the internet securely, and projects like Dolphin that use the internet should be allowed to use, good enough security without making the security too hard to use. Now this is another complicated slide. Don't worry, you don't have to read it. Our doctors are building electronic systems for outpatients, inpatients, medication safety, clinical notes, a lot of operating room, radiology information system. So this just shows you the plan as we build these many systems. All of these systems interact with each other. All of these systems share a common database. So the doctors have found they can go to one place on the web and do all the functions they need to do their work. I showed you already the chemotherapy system. So let me talk a bit about data sharing, like Dolphin. This is what a doctor's bulletin board looks like in the United States. We have over 1,000 insurance companies and no national healthcare system. So if you need a test, the first question a doctor asks you is, who is your insurance company? A doctor may want to order a test like a CT or an MRI that is expensive. So the doctor has to call, if you have Blue Cross insurance, the doctor has to call that phone number to get approval. If you have Tufts, this phone number. If you have Harvard Pilgrim, this phone number. This is crazy, having a doctor calling insurance companies whenever they want to order tests. So we built a system like Dolphin that sends clinical information between hospitals and insurance companies. It sends information between hospitals and pharmacies. It sends information hospitals to patients to make this much easier. The New England Health Electronic Network that I oversee sends 100 million transactions each year between hospitals and insurance companies to automatically approve tests and pay doctors for their work. Doctors do not need to make phone calls anymore. And I've shown you the e-prescribing, the connection between doctors and pharmacies. We do about 100 million transactions there each year. And this is new, clinical data sharing, sending, like MML, we use CDA-R2 to send data from a hospital to a hospital or a hospital to a doctor's office. These are the kinds of data sharing activities that we have built. So you have built an elegant system that goes from hospital to patient, patient to hospital. And we've done similar kinds of things. In addition, we have created a database to measure quality in the community that helps us give feedback to doctors to improve the kind of care they're giving. Now, personal health records are very important. I want to show you Google Health and Microsoft Health, actually how they work. So, I know that Japan is very concerned about privacy, so I'm going to use my lifetime medical record, and I give you all permission to see my medical record. It's okay. So we have software called Patient Site. And so I am going to log in as me. Now, when I log in, I am given access to many functions. So first, we have electronic mail between doctor and patient. Now, this does not use Gmail or any nifty.com. It is web-based, secure email between doctor and patient. It never goes over the internet unencrypted. Now, these actually are real email messages from my doctor to me, reminding me about appointments and telling me that I should get a flu shot. And so this is very popular because doctors and patients can now communicate without having phone calls or office visits. I have full access to my electronic records, so I can look at reports and problems. So in 2007, I had an arrhythmia. My heartbeat went to 200 beats per minute. So my doctor told me to go get a treadmill stress test. And so the good news is I'm okay. So I have access to all of my medications, my allergies, etc. Now, if I decide I want to use Google Health, all I do is click on the Google Health button. Now, why would I want to use Google Health? Well, it's like Dolphin. This is a very fine system if you get all of your care at one hospital. But if you get your care at many hospitals and many doctors' offices, many pharmacies and many labs, it would be very good to get all of that data in one place. So you, the patient, can now manage your lifetime medical record. So let's do this. I am now going to activate Google Health. The lawyers wrote this. This tells you Google Health is not covered by HIPAA. Google has no privacy laws whatsoever. You have to trust Google. Okay. I trust them. I was on Google's advisory board, and we built very strong policies. Google will never advertise based on medical data. Google will never share medical data. Google will never sell medical data. Okay, so I am now going to tell it, I have a Gmail account, jdhalamka@gmail.com. I'm telling it, link my Gmail account and my Beth Israel Deaconess record. Okay. So now I have linked all of my data to Google. I, as a patient, decide what data I wish to transfer to Google. I now push a button. It takes about 5 seconds or so. And you can see it's uploading. Okay. All of my lifetime medical record has just been transferred to Google. So let's go take a look. So there we go. I am now in Google Health. Currently, Google Health is only available in the United States. But I believe Japan would be a very good international test for Google Health. You can see it has uploaded my weight, my height, my body mass index. I had this episode where my heart rate went very high, and you can see that it has recorded that. I am a vegetarian. I'm a vegan, and so it has recorded that. It has recorded I take a multivitamin and vitamin D. I'm allergic to penicillin. In my shoulder, I have a chip with all of my medical records and my genome. Now, no one else in the United States has this. It's very strange. So, if you scan my body at 134.2 kilohertz, I emit my genome and my medical record electronically. It has my lab results and it has immunizations. So, what's nice about this is any medical records in the United States at LabCorp or Quest these are large laboratories. At pharmacies like Walgreens, CVS, Longs, these are our pharmacy chains. They're all connected to Google Health. So you can upload all that data. And you can see while I'm in Google Health, it knows that I'm a patient at Beth Israel Deaconess and says, would you like to make an appointment? Would you like to email your doctor, or would you like to refill your medicines? All of this can be done from one web-based screen. Now this is interesting. Now that all of my data is in one database, there may be other companies that I would pay to use my data in ways that would be useful to me. So for example, suppose that I did not believe my doctor at Beth Israel Deaconess when he told me my heart problem was just it's an AV nodal reentry. It's an AV nodal reentry tachycardia. You don't need to translate that. Fast heartbeat. Maybe I didn't believe my doctor. So I want to ask the Cleveland Clinic for a second opinion. So I can just push this button, pay $25, and all of my lifetime data will be sent to the Cleveland Clinic, where they will then do a second opinion. Or maybe, suppose I'm an older person and I have 10 different medications and I can't remember when to take them. This company will send an SMS to my cell phone every time I'm supposed to take my medication. So it will say, it's 8 in the morning, it's time to take your blue pill. Or this company called SafeMed will check your medical history for safety. It will check your medications and their doses. It will even infer, oh, you're a diabetic and I see you haven't had an eye exam this year. Talk to your doctor about getting an eye exam. This company does clinical trials. So suppose I have multiple sclerosis and I am interested in clinical trials for new medications. I can click this button, it will upload my medical record and decide what clinical trials I may qualify for based on age, gender, medical condition, and laboratories. So these are very value-added. The patients decide if they want to participate. Like Dalton, It is totally patient control. And I can share my records with any outside doctor or service. Now, rather than going into the Microsoft product, I'll just show you the slides of that. It's very similar. Microsoft has a similar linkage where you can, as a patient, upload your information into Health Vault. Health Vault has a connection to home care devices already, blood pressure cuffs, glucometers, and the idea with Health Vault is Microsoft has created a way for companies to create software that reads your data. And so, for example, it may take your glucometer readings and graph them for you. And so you can decide. It's like an iPhone with the App Store. You can use apps that will do interesting things with your data. Now let me just spend a moment talking about our experience with personal health records. So Dr. Yoshihara and I talked about, were there any problems with Dolphin? Were there any worries that doctors had about sharing data? Well, we have been running personal health records for now 8 years. I've done 2.5 million transactions. I have 40,000 patients every month using our personal health record. We've had no problems. No bad news, no patient complaints. Doctors are okay. There were worries that doctors would get too many emails, or that patients would see their laboratories and get worried by their results. Now, we did do a few things to make it less concerning for the doctors. For certain kinds of tests, like pathology and cytology, cancer diagnostic tests, or MRI or CT that may show that cancer has spread, we delay results by 1 week so the patient and the doctor can talk about the results, and the patient does not find out on patient site or Google that they have cancer. There are certain test results that the law does not allow us to show. If you go to a doctor for an HIV/AIDS test, we can't show the result on the web. You have to talk to the doctor in person about the results. But what we also learned is that you have to educate the patient. Just telling the patient your cholesterol is 200 isn't very useful. You have to explain, is that high? Is that low? What should you do about it? So we have partnered with several encyclopedias. Up to Date is one company. So the patient sees their problem list and their medications and their labs, but they have access to good electronic information. So in the case of Google, for example, it actually can tell me about my arrhythmia or about my medications. And Patient Site has very similar features. We also included an electronic medical dictionary so that the patients could look up words they did not understand. This shows you a little bit about the kind of volume we're seeing. So per 100 patients every month, about 28 emails are sent. This means an average doctor gets about 5 emails each day, and that replaces phone calls. So the doctors actually find it easier to return an email than to call a patient back. Patients really like renewing prescriptions and getting referrals. In the United States, you can't just go to a specialist. You have to get a referral from your primary care doctor. And making appointments on the web is very easy because you can see the doctor's schedule and make your own appointment on the web. It tells you a little bit about, because you showed the demographics of Dolphin. Many of our patients are women in their mid-40s. Now, your patients I saw were a little bit older than that, but there's a reason for this. In the United States, it's very common for the woman in the household to manage the medical care for the household, so that the woman in the household keeps the immunizations of the children online, tries to tell her husband to eat better and lose weight, and so this is because it's the medical manager of the family who's keeping all of the records online. Do they do that in Japan? So it's been a very good experience. And this is why I am convinced that Dolphin will be very successful. Because all of these things have been very popular features that patients at Beth Israel Deaconess have told me they will stay at our hospital because we have this electronic health record system. And in the United States, hospitals do compete. And so it's easy for me to justify the expense to the administration of the hospital when the patients tell the hospital, we like your hospital better because you offer personal health records. So I, every day, write about electronic health records and personal health records on my blog. In fact, tonight at midnight, I will be writing about Japanese health records and why I like them so much. I've seen the systems at Tokyo Medical University, St. Luke's, JFCR, Nagoya University, and now in Kyoto. And the Japanese medical records are very colorful, very visual, very easy to understand. So I really think the United States can learn something from the way that you have engineered your displays for doctors. So that will be going live later tonight. And you can feel free to email me at any time. I have my BlackBerry and my iPhone 21 hours a day, and I'm very happy to collaborate with anyone in Japan. So thank you very much, and I'm happy to take your questions.
田中先生、どうも貴重なお話ありがとうございました。インターシステムズジャパンの上松と申します。いつもお世話になりましてありがとうございます。お話の中で、この医療連携についておそらく患者さん、それから医療機関、それから政府という3つの、軸というかですね、大事な、存在があると思うんですけども、一つは、アメリカでこの医療連携を進めていかれる中で、その患者さんが自分の医療情報を管理するということに関して、日本ではおそらくまだそういった意識が非常に薄いかと思うんですけども、アメリカでどのようなその教育を、教育というかガイダンスというかですね、やっておられるかというところを大変興味を持ちまして、もしお答えいただければありがたいです。それからもう一つは政府が、当然その2兆円近い予算をつけてですね、こういった医療連携を推進するということで、医療コストの高まりというのはこれは各国共通の課題かというふうに思いますが、こういった医療連携が進むことによって国としては、どの程度のその医療コスト削減効果というか、なんか定量的なデータをお持ちかどうか存じ上げませんが、もし何かヒントになるような情報がございましたら、教えていただけると幸いでございます。
Excellent questions. So I should just say that all of the systems I showed tonight are written in cache. Not an advertisement for InterSystems, but they are very fast and very stable. So the first question about educating the patients. I know that only about 20% of our patients really want to manage their own health records. So 80% want their doctor to do it. So we do both. Patients that want to manage a personal health record, and patients who don't enable the doctor to do it. It turns out that personal health records through Google and Microsoft are now really becoming quite visible. And in the United States, there's a lot of talk about more and more personal health records. So I think it has been an education. It has been picking the early adopters, those patients who want to do it first, and they tell friends, and before you know it, more and more people use personal health records, and the visibility of Google and Microsoft has helped. But I want to emphasize, you must do both, personal health records and electronic health records, if you're going to cover the entire population. The second question, I'm going to give you a few numbers. In Massachusetts, where I live, we estimate 15% of lab tests and radiology tests are redundant and wasteful. In Massachusetts, we spend, I'm going to give you dollars, $30 billion on healthcare each year. 15% is $4.5 billion. In Massachusetts, we believe electronic health records and personal health records could save $4.5 billion per year. One other number for you. The RAND Corporation has modeled healthcare in the United States and believes through reduction of error and through better coordination, the United States will save $100 billion per year through the use of electronic health records.
Dr. Halamka, thank you very, very much.
他にございませんか。はい、どうぞ、菱木さん。
東邦大学の菱木と申します。Google ヘルスは、私自身使い始めて非常に、面白いと思っているところなんですが、でまたこういうふうにGoogle のようなところが一箇所にデータを集めることができれば、それはもしかしたら究極のそういう健康情報の管理になるかもしれません。ただそれはGoogle が永続的であればということだと思います。で、企業にはライフサイクルがあるように、ですからジェネラルモータースと同様に、Google も永遠ではないはずなんです。ですからそういう時に備えて例えば、Google ヘルスと互換のシステムが他でも立ち上げるようなことは可能なんでしょうか。で、現にGoogle はこの前Google ノートブックの新規利用者の更新を、停止して、私は Google ノートブック非常に気に入ってたんですけど、非常に残念でした。
So, another excellent question. Google is very concerned about interoperability, and I have worked with them on their standards. Today, they use a standard called the Continuity of Care Record, but they are planning to use this CDA R2, so similar to what you are doing with MML. Though today, you can send data to Google and share it, there isn't a function to export everything from Google in the case that Google goes out of business. They are building that, however. That is definitely in their plan, so that you will be able to move data from Google to Microsoft, or download it and put it on a USB drive. So I think your concern is valid. Your GM example was perfect. I drive a Toyota. Prius, good car. And it is absolutely essential that a personal health record is interoperable, because companies will come and go, and we don't want your personal data locked up by any one company. So this is coming for Google. And just to show you what the data will look like, this is my lifetime medical record in this CDA R2, the Continuity of Care document format. So you can, this is the human readable version. It includes my problem list, my family history. Oh, and my parents also give you permission to see their medical record. It's okay. Social history. And it is all, as you can see, I just show you the XML. This is the source. So everything that you can see on my lifetime medical record is structured XML data. And so this is what we will use to get data out of Google and into Microsoft or under your control, however you wish.
じゃあ他にどうぞマイクお願いします。
探索医療センターの住と申します。こういう話は初めて聞きましたので、ちょっと素人的な質問で申し訳ないんですけれども、お話の中で医師と患者が、この EHR か PHR、こういうものを使ってコミュニケーションができるという話があったと思うんですけれども、それについてもう少し詳しく教えていただきたいです。特にその患者さんの方から何か医師の方にメールなり連絡が入った時には医師は必ずそれを見なければいけないのか、そういう時に費用は発生するのかとか、どういうふうにされているのか教えていただきたいです。
Another excellent question. Thank you. So this does not use regular email because regular email is not secure. What happens is a patient goes to a web application, writes a message to the doctor. The doctor is notified on their regular email that a message has come in, and then the doctor logs into the web application to read the message. It is understood that the doctor has 3 days to respond to an email. We tell the patients, don't expect an answer immediately. We also recognize that there is going to be some additional time taken by the doctor to do email. But, as I said, the doctors have to date seen that it replaces phone calls, so it actually takes less time to do an email than a phone call.
よろしいですか。はい。で他にございませんか。まだ時間があります。あと4分ぐらいありますけど。いかがでしょうか。あ、どうぞ。
北野源藤川と申します。Too many standards、標準が多すぎるとおっしゃっていました。で今後どのような標準が主流となっているかお聞かせいただけたら幸いです。
Well, what we are seeing is that there are 2 basic kinds of data exchange. One is a message. So, for example, if a doctor orders a lab and the lab sends back a result, that's a message. HL7 251, HL72 is what we have been using. The UK and Canada have been using HL73. We have found it's too complicated. So HL72. The other kind of data exchange is a document, like my lifetime clinical summary. That's where we use the HL7 Clinical Document Architecture, CDA. Those seem to be the 2. Now, of course, within those, there may be vocabulary, like SNOMED, to describe a problem, or RX norm, to describe a medication. So this few standards will probably be about 10 standards, 1 for messaging, 1 for documents, and several for vocabularies.
よろしいでしょうか。では最後の質問と1つ、はい、どうぞ。
すいません。私はこちらの方の医学研究会の専門の方は看護なんですが、今お聞きしてますと医師と患者というふうな状態での連絡ですが、これはヘルスケアのデータベースですが、その看護側だとかあらゆる医療の 関連の人たちもアクセスして一人の患者さんのケアというものがこのデータの中で交換ができるのでしょうか。
So, I apologize if I used the word doctor when I should have used the word clinician, because anyone who delivers clinical care, doctor, nurse, social worker, pharmacist, all need to use the same system. We use the term multidisciplinary documentation. So this is when I said it's like MIXI. It's all professionals coming to contribute to the patient's lifetime medical record. We have many workflows to support nursing charting, electronic medication administration, similar to your barcodes, scanning patients and scanning medications, provider order entry, where doctors and nurses work together on orders. So yes, every member of the team uses the system.
はい、どうもありがとうございました。それではまだご質問たくさんあると思いますけれども、予定の時刻も過ぎてしまいましたので、ここで終わりにしたいと思います。今日はお天気の悪い中、たくさんお集めいただきましてありがとうございました。もう一度、ジョン・ハルムカさんと通訳の徳丸さん、拍手をお願いします。